Hi there, and welcome to the White House. We're incredibly excited about this event in the Precision Medicine Initiative overall. I just wanted to offer some perspective from the White House point of view. I will be brief so we can get into the substance of the discussion and to the role that all of you can play in helping us move this agenda forward. I guess the first thing I wanted to just let you all know is that this is an issue that is of a personal significance and a passion for the President. And as Francis and I know, he, over the course of time, has really been thinking about this question of innovation, technology, biomedical research, and how we can do more as a federal government to really accelerate the progress that we have seen over the last several years. So one of the things that he asked us several months ago was to think big and try to envision what we could do in the final 2 years, the fourth quarter of his presidency, to really move precision medicine into a new space. I don't need to tell you all that obviously this idea of precision medicine is much older than the last 6 months since the President launched his initiative. And this has been, a goal of the biomedical sector for decades. And in fact, it's all of the groundwork that you and others have laid that puts us at this moment of time with this moment of opportunity. But I think what's exciting from our perspective is that this PMI initiative and the President's focus and direction to all of us has allowed us as a federal family to come together with a laser-like focus on what we can do, from investments in research to regulatory changes to better engaging as a federal government to try to accelerate progress in this area. So we've got a lot of exciting and impactful work going on within the federal government to try to advance this forward. As Francis will speak to, NIH is driving the process of designing a research platform of unprecedented size and scope to answer outstanding questions that have prevented the development of effective therapies and prevention strategies for many diseases. We view this as a data commons, something that will be openly available to qualified researchers and should hope expand the pace and the scope of research quite substantially. We also hope that this helps to change the relationship between researchers and patients and participants. We view participants as true partners in this effort. We also recognize that making this a true partnership will take trust and commitment on our end to ensure that we're following through on the goals of privacy and security that we have set out. So to that end, today, we have posted a set of foundational privacy and trust principles for the Precision Medicine Initiative. I encourage all of you to look closely at this. It is a significant document. It reflects a lot of work that we have done internally, but most notably, we need all of your input. We put this forward publicly precisely because we want feedback, we want input, and we want this to be a partnership. We've spent a lot of work trying to refine this, but I'm confident that we don't have everything right. Joe Handelsman will talk a little bit more about this in detail, but I really encourage all of you to engage with us on this issue going forward. We're also looking at policy changes that we may need to make as a federal government to remove hurdles that may stand in the way of making precision medicine more widely available, and also to protect and enhance privacy and security. To give one example, FDA is now working to define a regulatory framework for genomic technologies that balances patient safety and innovation, but reflects the fact that the market and innovation have driven real changes, and our regulatory infrastructure needs to respond. So the thing that I think is, we also need to think about how we move those policy changes to reflect the incredible enthusiasm and activity that we're seeing in the patient and participant community. I think increasingly what we're seeing across the country is that people, as technology changes and as we all can execute complicated financial transactions from our cell phones or from anywhere, that people are demanding more immediate and accessible data about their own health. People are producing that data on their own in new and innovative ways. And what we'll hear from today is groups that are committing to take game-changing actions in this space. And what, in the most ideal vision, this should be something that is incredibly easy for every American, that it is as easy to compile, access, aggregate, and share your health data as it is for me to buy a plane ticket from here to Beijing in 30 seconds on my phone. In order to get there, we're going to need people to participate. We're going to need people to donate their data for science. We are going to need people to be active participants and partners with us in shaping this process. And what's so exciting to me about this event in particular is it underscores how much we have to learn from what's happening across the country. It's incredibly exciting to see new and innovative technologies being piloted in this field, especially given the patients' easy access to their health data, empowering them to contribute in the ways that we know we will need. But I guess the thing that I would like to leave you with as we go into more detail about these new and innovative strategies is, just as the President has challenged all of us at the federal government to do more and to push harder, I would challenge you all to think about how you can do more over this next couple-year period, how you can use the power of your own voice and the power of your organizations to accelerate progress. Today, we're going to highlight 5 amazing organizations and scores of their collaborators who are committing to give patients easy access to their health data and mechanisms to participate in research. This is inspiring, and this is great. But I'd like to see us quadruple or increase by tenfold the number of those organizations that are participating and making commitments along those lines by this fall. I think that we can see easily 20 different pilots offering solutions for individuals to seamlessly access their health data and donate it for research. I think the will and the technology are out there, and I would like to challenge all of you to think about how, over the next several months, we can bring together different teams of technologists and patients and researchers to test these solutions, to engage in more pilots, and get more activity out there, which will ultimately both spur progress and help us in the federal government learn from everything that you're doing. I think at the end of the day, all of us come back to a very personal and urgent motivation for this work. The fact that there are too many diseases without effective therapies is something that is not just a national policy issue. It's an issue that affects millions of Americans, our family members, our friends, our friends and neighbors. It affects them in real and tangible ways on their most personal and vital issue of their own health. And everyone needs access to a health system that works. President Obama is unbelievably committed to an overall reform of the healthcare system that, when we leave office, will allow all Americans to access high-quality health care without ever again in this country having the fear that if you get sick, you might have to go bankrupt or lose your health insurance. Precision medicine is an incredible opportunity to build on that foundation and leave for future administrations and future generations a health system that can actually get to those effective treatments and help so many of us and the people that we love. So I want to thank the champions that we're going to highlight today. Thank you for your work. Thank you for stepping up and sharing with us the efforts that you have underway. Thank you for making commitments to do more and be more aggressive. And I would encourage all of you and to use this forum to think about what more we can do together collectively. So with that, I will turn the podium over to somebody who needs no introduction in this space, but I will say is a true champion of this precision medicine initiative and of the unbelievable transformative power of basic research in our country, Dr. Francis Collins, Director of NIH.
Well, thank you, Brian. Good afternoon to all of you. I had the pleasure of meeting with the champions of change earlier, and I'll be introducing them to you here in a couple of minutes. And let me say, I found the conversations I had with them inspiring, all of them taking various innovative approaches to this space of precision medicine that you'll be able to hear about in the course of the panel discussions that are going to occupy a significant chunk of this special afternoon. And thank you to all of you for being here at the White House to take part in this, because I know there are many other activities that have been happening during the course of the day. And we'll have other speakers folded into this afternoon's program who have interesting and exciting things to tell you about. So all of you who are gathered here, I think, are change makers, and that's what we're here to talk about, the champions of change, in this case, precision medicine. I could quote from somebody who seemed to have said a lot about change. President Obama wrote these words: "Change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek." Gathered in this room very much represent the change that we all seek to understand better how to maintain health, how to manage the illnesses that occasionally strike in an optimum way, how to transform the practice of medicine into something that is empowering to individuals, that puts them at the center and allows them to make those decisions that are going to be best for themselves. And with this precision medicine initiative as a leading edge of how to get there, we have very high hopes of a transformative experience in the coming years as this takes shape. And I must say, it has been inspiring to spend time with the President of the United States, who I'm fond of calling the scientist-in-chief, because of his personal interest and deep knowledge about this area, which he has done a lot of thinking about and has certainly led all of us to think big, which is what we're here to do this afternoon. Our cause is good. We're seeking to change the way that medicine is practiced. Traditionally, doctors have had to make recommendations in most instances about disease prevention and treatment based on the expected response of an average patient. Precision medicine seeks to change that by taking into account individual differences. Now, you might say that's not entirely new. If you needed a blood transfusion sometime in the last decade, you'd probably want to be sure that it was actually matched for your blood type. If you went to have your eyeglasses adjusted, you probably didn't expect to get a generic pair of spectacles. You wanted something that was actually appropriate for your particular version of nearsightedness and astigmatism or whatever it is that afflicts your eyeballs. I know there's plenty that afflicts mine, and I'm glad there's precision eyeglasses for that purpose. But for most things, the tools, the technologies, the scientific understanding, we're not there yet. But we want to get there, to envision ourselves benefiting from a more precise and customized approach to medicine. That's what the President was seizing upon when he introduced this idea at the State of the Union message last January 20th, and then explained it in greater detail 10 days later in the East Room at an event that several of you that I've seen today were also present for. We at NIH are truly excited to be able to take a significant role, but not the only role. We have many partners in this effort represented in this room across government, and certainly with patient organizations and with industry. This is going to have to be an all-hands-on-deck effort to succeed. And every indication is that that's happening, and that is gratifying indeed, and today is another example of that. So what's the plan for the Precision Medicine Initiative if we're going to start this, as the President has charged us to do, in the latter part of this year? Well, first of all, we have a plan for a near-term focus on cancer. Significant strides have been made in that space, learning the molecular signatures that cause cancer to happen and distinguish cancers from different individuals in important ways that have consequences for our understanding about what's likely to happen and maybe most importantly, what therapy is likely to work. Precision Medicine Initiative intends to capitalize upon that historical opportunity by expanding that effort in significant ways, to be able to establish a cancer knowledge network, to come up with new strategies to match for the individual what you find in their cancer genome with what actually would be most appropriate as far as therapeutics, and to extend that from what has been already a pretty bold effort, looking at targeted therapies, to combination therapies, which may hold a higher opportunity then of a cure than what we've been able to do with single drugs. And also to understand what's resistance about. If the drug seems to work and then it stops working, what happened there? And how could we understand that and adjust our responses accordingly? So this is a bold but very near-term effort that we think the Precision Medicine Initiative is ideally suited to nurture and push forward. In the longer term, and even perhaps more bold and ambitious, we aim to try to apply this individual approach to all of medicine. And that is to establish this national research cohort of 1 million or more individuals who will be at the center of the design. We don't think of them as patients, we think of them as partners, as participants. They are going to, and already are, help us with the many critical questions about how to design this in a fashion so that participants benefit by their engagement in this effort, that they are very much involved in decisions about who has access to the data and what kind of data gets collected. We imagine that we can start this actually fairly quickly by taking full advantage of the fact that there are such cohorts in various places that have begun to be established. A particularly prominent one, the Million Veteran Program, which has already enrolled about 400,000 veterans and have begun to obtain DNA information on many of them. In addition, there are cohorts that have been established by healthcare delivery systems like Geisinger and Kaiser Permanente and Intermountain and Mayo and Marshfield and others. But putting those together in a synthetic way would greatly increase the power of the effort, of course, with full understanding and participation by those involved in those studies that they want to take part in this. We don't take that for granted. We need to find that out. We've recently done a survey, though, of 2,600 people across the country in a statistically representative way. It's gratifying to see that 79% of them thought that the idea of having such a national cohort study was a good thing. And more than half of them said they would sign up. And interestingly, that was agreed across multiple different backgrounds. It didn't seem to matter what your ethnic group was, or your socioeconomic status, or your educational level. There was a little bit less interest, not significantly, but a little bit less as people grew older, which we were surprised by. But otherwise, it looked like across the board, pretty genuine enthusiasm for this effort, which is important to see. So the plan would be then to ask participants to provide consent for access to their electronic health records, and hence the need for those to become really usable for research purposes, which Brian has already talked about, and which is a big challenge that this initiative can address. But also to have DNA analysis carried out, ultimately complete genome sequences on 1 million or more people, which sounds astounding to contemplate, considering that it hasn't been that long since we got the very first human genome. But the price has been coming down at a really gratifying rate, and it's now possible to imagine such a thing. And perhaps also to ask these individuals to collect other information about themselves in real time, exposures to environmental substances using wearable sensors, as well as all kinds of other things which with mHealth, so-called mobile health efforts, we could collect, and therefore greatly enrich this data set. Again, the idea, trying to figure out what works to keep people healthy, and how does the individual characteristics of this very large group feed into getting that answer right and not having just a generic response. And similarly, for chronic illness, for hypertension or diabetes or heart disease, how do we make sure that the ways in which we manage those illnesses are taking full advantage of new technology and incorporating what we've learned about the individual? That's our dream. That's our promise that we aim to try to carry out. With this sort of unique moment in history, I don't think we could have necessarily done this 5 years ago. I actually wrote a paper 11 years ago proposing it, and it kind of didn't go very far because it was utterly impractical at the time. But now, with the advent of electronic health records, with technologies that are coming down in cost and therefore becoming more accessible, and maybe most importantly with participants, with the public, increasingly interested in this kind of information and in taking part in projects of this sort, we have a wonderful coalescence of opportunity. And we aim to take that with great respect for those who are interested in taking part, to listen closely to their ideas. And we just had a very intense two-day workshop last week at NIH about this, to take account of those privacy principles that you heard are being rolled out today. And please have a close look at those and provide feedback to what you see there. All of that being done, I must say, at a rather rapid pace here, trying to have this design for this million-strong cohort ready for approval of some sort by September, so that we can get this underway before this year is over. And that is moving at a remarkable pace, but we are impatient, and I know you are too. So that's really what this is trying to lead to. And on top of that, as you've heard, we can't make any of this happen without the participation of people from many different backgrounds. And hence the idea of this Champions of Change opportunity that we're here to celebrate this afternoon. Now, there's so many champions out there. The 9 folks that I'm going to introduce represent clearly a large cadre of individuals who have rolled up their sleeves in all sorts of settings to make this kind of momentum possible. But this is a remarkable group, nominated by others, put forward, reviewed in a way to make sure that their activities represent sort of the best of the best, and it is therefore a great privilege, I think, that we all have here to hear from them this afternoon and to celebrate their accomplishments. So it's my great pleasure to welcome to the stage each of the outstanding individuals that we're celebrating today, and I'll ask them to come up one at a time and perhaps stand here in the front and stay standing until all 9 have arrived on the stage. And I'll ask you to hold your applause until we get them all up here, but I know that will be difficult because these are all people that you will want to applaud for. You'll get your chance, don't worry. So, and you have bios in the materials I hope that you have seen, and I'm going to introduce them in alphabetical order because otherwise I don't know what I would do. So we're going to go with that. So first, please, can I ask Marcia Boyle to come and join us here on the stage. Marcia is president and founder of the Immune Deficiency Foundation. She's devoted her life to helping people with primary immunodeficiency diseases. Through her foundation, she is helping patients track and manage their health with the use of electronic personal health records. You get the connection in a very specific way. Next, Hugo Campos, data liberation advocate and leader in the e-patient movement. Yes, please come join. After receiving an implantable cardioverter defibrillator to help manage an inherited heart disease condition, Hugo has become an advocate for those seeking to gain access to their own health data and improve their health through a more targeted approach to their care. Next, Elizabeth Cohn, Director for Health Innovation at Adelphi University. Elizabeth has dedicated much of her career to addressing and seeking to reduce health disparities. Her recent work has focused on engaging individuals from traditionally underserved communities, particularly through faith communities in New York City, on the topic of precision medicine. Next, Amy Gleason, Chief Operating Officer of CareSync. Over the past 5 years, Amy has drawn from her experience as a caretaker for her daughter and as a nurse to help patients and their families organize and understand their data to better coordinate care and improve health outcomes. Next, Amanda Haddock, co-founder and president of Dragon Master Foundation. Following her son's brain cancer diagnosis, Amanda has become a champion for speeding biomedical discovery through her foundation, which aims to build a research infrastructure to empower cancer researchers as they pursue precision medicine approaches. Next, Emily Kramer-Golinkoff, co-founder of Emily's Entourage. As a young woman with cystic fibrosis, Emily is leading an effort to raise awareness and accelerate new treatments for rare cystic fibrosis mutations, with the aim of harnessing precision medicine approaches for a greater number of patients with this disease. Next, Howard Look, founder and CEO of Tidepool, a self-described geek dad. Howard was spurred to action by his daughter's diagnosis with type 1 diabetes. He's working to help patients better manage their care through better access to health data and tools. Dorothy Reed, president and co-founder, Sisters Network of Central New Jersey. Dorothy co-founded and leads a network of breast cancer survivors in Central New Jersey that aims to educate, support, and bring awareness of breast cancer to African American women in the region, work that encourages their participation in research on precision medicine. And finally, Anish Sebastian, CEO and co-founder of Baby Scripts. Anish is working to harness technology and data science to improve prenatal care by providing detailed information to patients and their doctors. Now, let's have a hand for all of our champions. Again, thank you all for being here today. Some of the champions are going to stay up here for a panel, and I'm going to turn things over to Faye. Thank you all.
Thank you so much, Dr. Collins, and congratulations again to all of our panelists. I am also going to invite up to the stage Matt Might, who is a visiting professor at the Harvard Medical School and actually joined us for our launch event for the Precision Medicine Initiative and got to meet the president then to lead this next panel.
All right. Thank you, Faye. Well, first, I want to congratulate each of you on your achievements, and thank you for taking the time to come and share your wisdom and experience with each of us. So as the father of a precision medicine patient, I can tell we have a lot to learn from you. I'd like to encourage the audience to start thinking of questions that will really leverage the expertise you have arrayed before you so that we can unlock what they really have to tell us. If you're watching on the live stream, I'll remind you to treat your questions to the hashtag WHChamps. We'll have an opportunity to take some questions from Twitter as well. And in keeping with that theme, I'd actually like to open with a question from Twitter. So we actually have one from none other than Kareem Abdul-Jabbar himself. So if you're not aware, he is in fact a precision medicine patient who also attended the launch event, has been actively engaged and interested in these issues. So to give you a chance to tell more of your story, your background, and how you got here before we get into some targeted questions, I'd like you to answer Kareem's. So he says, I've seen firsthand how precision medicine can help. How did you get involved in this area of medicine? So, Dr. Cohen.
So I guess I'll start. I'm going to use the microphone. As somebody who watched the live stream, I just know that they need it for the people who are watching. So thank you. It's a privilege to serve on this panel and to have the opportunity to share my work and to be among these champions of change who have truly inspired a lot of the work that I've done. I'm going to try to wrap 32 years of work into just 5 minutes or less. So I just want to say that I started out as an emergency department nurse for many, many years in some of the very poorest places and with the underserved, and then in some very privileged places in Long Island. And that lens let me look down and see the effects of the social determinants or the modifiable root causes, but also the random effects of disease on people of every type of socioeconomic status. So things like childhood cancer that ran across all of the economic categories. So it gives me a unique approach, which really wants to think about how we can fix the modifiable root causes and then how we can identify and help those that are not. In 2004, I was a cardiothoracic nurse practitioner when a drug came out that was marketed specifically to blacks and African Americans. And a longtime patient that I had looked at me and said, "Are you sure this drug is good for me? Is this really the right one?" And I said, "You know what, we actually don't know. We really don't know." And that was 15 years ago. So for 15 years, I've been trying to answer the question, given my characteristics, is this drug or treatment the right one for me? And that has morphed into the precision medicine that we've been thinking about today. So my twofold mission is to ensure that people have a chance to understand clinical research and that we partner with communities so that they own it. I'm here because we developed an interactive graphic novel on precision medicine, and I'll talk more about that after. The community that developed that in Harlem has been developing it for 2 years, and they own the effort. So on that side, and then also people want knowledge and they need to benefit from understanding the risks of participation, but also the risks of non-participation. And those risks are high because it contributes in a not positive way to the health disparities that we see today. So lastly, I chair a committee for researchers who are interested in patient-centered outcomes research and community-based research at Columbia University, and we help them try to understand what they can do differently so that the research and the results are owned by the community. So as we launch this important initiative, we have the opportunity to make sure our work in this helps us achieve health equity across our nation, and that my work contributes to that. So thank you.
Well, I'm also very, very honored to be here today, and the way we got involved with this is, I think, typical to a lot of people in the room, a very personal connection. In 2010, my son was diagnosed with GBM, which is the same brain cancer that Ted Kennedy died from. So we sort of initially knew that money wasn't going to fix this problem, that if we were going to have any hope of saving David, it would have to come from innovation. So we traveled near and far to a lot of different hospitals. We came to NIH. We, I think, got the very best care available to him at the time. And he participated in some clinical trials. Unfortunately, there just weren't very many answers, and still aren't, for brain cancer patients. And as we were going through those treatments with David and talking to researchers, we started to understand some of the problems that they face. And there are huge problems that they face with sharing data. And the deeper in we got, the more we realized that we had some unique abilities to be able to share with them. My husband has a computer programming background. I knew a little bit about databases, and it occurred to us that, you know, we can go on Facebook and it'll tell us what friends we should have, or Amazon can tell you what potato chips to buy, but no one was telling us what targeted therapies would work for our children. And David passed away, unfortunately, in 2012. We're on the cusp of some targeted therapies that I think would have helped him, but they weren't available then. And even now, the success stories that are out there, we're still not really sure why those patients are doing well. On clinical trials, you see some that are doing very well and others that are not. And precision medicine is going to really help us figure out who will be successful on certain therapies. So what we're working with is really trying to put all of the data in one place, much like the NIH genomic cloud that they're working with. We're bringing pediatric data into that space. They're pulling data, I think, mostly from the Cancer Genome Atlas and some other large projects like that. But those projects haven't traditionally worked with pediatric data. And we think it's important for a number of reasons to have pediatric and adult data in a data set alongside each other so that you can see what the similarities and the disparities are. So, our mission is really just to create this sort of global database that everyone can share. That our pilot is starting with brain cancer because that's sort of the background that we had and what we knew about, but the potential to impact all types of healthcare is definitely there, and when we're collecting genomic data, we don't really see a reason of repeating that in multiple little databases. So we really want a global database that everyone can access.
My name is Dorothy Reed. I am a 15-year breast cancer survivor. I got involved as an advocate 15 years ago when I was diagnosed with breast cancer, and my doctor asked me why were Black women dying of this disease. I did not have the answer, but it made me wonder why women are dying 40% more than other ethnic groups. So Sisters Network, we do not treat the disease, but we treat the survivor with hope, kindness, and one-on-one support. We encourage them, and we're still out there trying to bring to light to women that they should get involved in clinical trials because clinical trials save lives. We're also trying to get research to look into why there's such a big difference between survival rates. Even after diagnosed, we are at a 5% less survival rate than other ethnic groups. I think it's education that's needed in the community, and that's what our mission is. Our mission is to bring awareness and education and support to our community, and we do that several ways with fundraisers and walks. And I hate to say that after 15 years with our organization, we're a national organization located in central New Jersey, we still lose about two or three women a year to breast cancer. It seems now that triple negative is something that's impacting African American women again at a much higher rate, and the women are younger, even before mammogram. So there's a lot of issues. We try to encourage women to get mammograms, yearly mammograms. We find that in our community. Sometimes women will skip a year, and that's why education, I think, is the key, and it's important. So we have projects that center around encouragement of mammograms and encouragement of yearly clinical exams. So there's a lot of work to do. I'm glad to hear about precision medicine. I think that is something that will benefit our community, especially because it's going to be concentrating on studies, and that's what I think we need, more geared studies to what our disease is in our community. And also, if you could write different research grants or proposals, I think sometimes it's the behavior. We always look at the disease, and a lady goes in like myself, and automatically you're given a 40% less chance of survival. I think if we back up and look at disease prior to being diagnosed, what was I doing 5 years before I got breast cancer? You know, what was I doing, any kind of preventive medicine? I think all that has to do with survival rates, and I'm glad to know that the White House is, President Obama is pushing precision medicine. I think it will help us.
Well, thank you. It's very much an honor to be here. It's an honor for the disorders that I represent, a group of more than 250 rare diseases called the primary immune deficiency diseases. Well, I got involved many years ago, 35 years ago. Essentially, my son was born with a rare disorder called X-linked agammaglobulinemia. Very ill, 6 weeks in pediatric intensive care at Johns Hopkins, and luckily he's in the audience doing very well. But it was very upsetting to realize there wasn't an organization for this group of disorders. So my husband, also in the audience, and I and a small group of people decided, let's create a national organization for the primary immune deficiency diseases to improve education, research, and the quality of life of these disorders. So in the early years, you know, we did a great job, the first educational materials in the world, a lot of awareness, but over time it became evident that what was really needed was data. These are rare disorders. There are a few of one type of disorder at one center, a few at another center, and no one had the real perfect look at what really was happening, whether it's X-linked agammaglobulinemia or severe combined immune deficiency, which is what the boy in the bubble had, or chronic granulomatous disease. So we actually developed, we are very pleased to win a grant from the NIH for the first registry in the world for primary immune deficiency for chronic granulomatous disease, and we've been running registries since then, now under a grant, again, from the NIAID for the USID-NET patient registry. But that wasn't enough. Our patients have a lot of issues that perhaps are not seen by every physician. They see many different specialists, and the information in the registry, over 4,000 patients, is fabulous, but it doesn't give the whole picture. We decided to develop an electronic personal health record for our patients. And we did that in 2011. It was very good. But then in 2014, two big things happened. First, we had an idea of listening to PCORI that, wait a minute, we're all about patient power, and so is PCORI. And we were pleased to win an award to create a patient-powered research network from PCORI, one of 18. And also there are 11 clinical research networks. And with that award, we decided our EPHR, where the whole idea is let's combine the patient experience from the electronic personal health record into the USIDNet registry, the clinically validated data. And oh, by the way, let's build a research forum to bring the researchers and the patients together to collaborate. But we decided to totally redo our EPHR, very exciting upgraded platform with Get Real Health. And with that, we can do quality of life surveys, sync with Microsoft Health Vault. It syncs with Blue Button technology with EMRs. So what we're trying to do is bring the patient and the physician, researcher together and give a much clearer idea of what's really happening with these patients to improve their treatment and to develop much more exciting therapies. And already from our research forum, some really interesting ideas are coming. So stay tuned. Thank you.
Hi, I am so honored to be here among this amazing panel and all of you. It really is such a thrill. I am a 30-year-old with advanced stage cystic fibrosis, and as you may have heard, there have been really enormous game-changing breakthroughs in the past few weeks, even and years, and actually this past week, there was quite a big one. But unfortunately, I have a rare mutation of this rare disease, and there haven't been any breakthroughs for us. And so watching all these breakthroughs come down the pipeline, you know, I had the choice of whether to stay on the sidelines or to get in the game. And so in 2011, my family, friends, and I decided to form Emily's Entourage, a 501c3 that has since raised $1.5 million to accelerate research for new treatments and a cure for rare nonsense mutations of cystic fibrosis. And so we are, you know, in addition to providing grants and trying to support different research, we're also keenly aware that one of the big barriers is just sort of focus and coordination and also urgency. And so with, I have advanced stage disease. I have about 35% lung function at my very healthiest. And we are painfully aware that time is of the essence. And so if there is one thing I can add, you know, to try to move things along, it's urgency. And so that is what I'm doing, in addition to also providing, you know, we realized that cell models were another big barrier, so also providing cellular assets to different institutions and really trying to do anything we can because, you know, the story of precision medicine is really, this is the fight to save my life and the lives of other people with rare nonsense mutations. And we're just so encouraged to see it, you know, get on this scale and see so many people behind it. It gives me hope that we can change this.
Great, thank you. So to start following up, I think a number of interesting points came up. So with both Dr. Cohn and Dorothy, we heard concerns about equity and questions of, you know, will this medication work for me? And that's going to require a new degree of inclusiveness to answer these questions across the U.S. population. So I'd like to open by saying, you know, how do we ensure that this initiative really is inclusive and representative, if that's the right word, so that we can answer these questions? And how is it that we get traditionally underrepresented groups to engage in clinical trials?
I think, for one, with clinical trials for African American community, you have to deal with the trust issue. Our history, our past have not been great when you think of Tuskegee or you think of Henrietta Lacks. I think when you go into the community, first you have to address those concerns to say, yes, this happened, it was true, but these things cannot happen now. They have certain things and policies in place where you just won't be used and never notified. I also think it's education on what a clinical trial will do for you. Okay, clinical trials is going to help you live longer. Clinical trials is going to track your disease more specific. You're going to have several doctors that's going to look directly at you. And also, I think access. A lot of times when women go to the doctor, they don't have the access. Sometimes their doctors never mention to them that there's a clinical trial. So sometimes it's the hospital or the center that you go to for treatment to make sure you're going to a place that offers every option to you. So those are the things I think they need to cover with clinical trials.
I agree 100%, and I thank you for saying that and for putting those issues forward. I framed my answer about inclusivity in the socio-ecologic model, so the individual, the interpersonal, the community, and then society at large. And I won't repeat anything that you said, but I support everything that you said completely, and some of my answers touch on that. From a societal level, in this initiative, it's going to be ancestry. It's not the social construct of race. So I think we have to be careful that we're mindful of the fact that those are two different things, and we want to bear that in mind. Right now, the groups that we have people in, Asian in particular, includes people from Bangladesh, Pakistan, China, Japan, Singapore, Sri Lanka. That's not going to be a designation that's going to help us so much in this initiative. I think that the group needs to be inclusive. We had talked a little bit that it's not going to be a representative group, but it should raise questions. It may not help us necessarily find the answers for some of the small subgroups, but it will help us identify and answer the questions. In terms of partnership with underrepresented communities, we need to establish the partnerships now while we're launching the initiative. It's a critical time. They need to be involved in the design, the execution, the analysis, and the reporting of the results. Really the patient-centered outcomes research model. And actually, I too am funded by PCORI, and for some of that work in a Native American population. So I think if they get on board now, I've heard in my focus groups people say to me, I want to be in studies. I don't want the study to be delivered fully. I want to understand what it's about. I want to help design it, and then I'll participate. And that's really what the direction that we're headed in right now. And I think we need to consider all of the populations that have been underrepresented. So the traditional minorities plus people living with physical and mental disabilities, people on the autism spectrum and their families, LGBTQ populations, the populations that aren't currently plugged into the system. So we have access, we have issues of access, and I think most of the questions come down to that. I think in this initiative, we have the opportunity to think about those who are born into and living with poverty. These are conditions that we've assumed to be transient, but they are unfortunately and remarkably not as transient as we wish they were. So people who have early exposure to violence, low social attainment, and low social cohesion. And I also think we want to know what's protective. So who's healthy under what circumstances and how we can tease that out. And I think that's going to be a critical component for inclusivity. I want to include people whose health is deteriorating, but who's able to stay healthy and why. And I say that with caution because I actually believe that context and community drive health, and it's not exclusively individual agency. But I do think that there may be some protective factors that we can consider. I think we need to separate out education about clinical research from consent for studies and start by educating communities, which is what my work and your work, all of our work is doing now, to talk to the community about what is clinical research and why should they participate, really the message that Dorothy was delivering. And so lest we lose the opportunity to do that, I think we need to use this precision medicine initiative to talk to all of our communities about the power of research and data. We heard testimony last week about the Precision Medicine Advisory Panel from parents and from scientists and from people who are demanding research on their conditions. There's urgency in Emily's story. We can see from this panel that people who are engaged receive action and benefit. And so my call is for those benefits to be realized for health equity across the nation. So I think those are some of the considerations.
Thank you. That's a wonderful summary of the issues we face when it comes to inclusivity. But I think there's some other groups that we have to consider in the context of this initiative. And one that we often don't think about as a group is children. And so, when it comes to, finding targets for children or drugs for children today, we sometimes treat them like they're 30-pound adults. And it's not necessarily to their benefit. So Amanda, you've had to face this personally in the context of your own precision medicine journey. Could you comment on some of the challenges that are out there in terms of pediatric health care and precision medicine?
Sure. We did face it personally. My son was 16 at diagnosis and was 18 when he passed away. And so a lot of times we were sort of on that cusp of, do we treat him like an adult? He was 6 feet tall, so he certainly looked like an adult. But what we've learned about pediatric cancers is that they act much differently than adult cancers do. So there's a great need to look at those individually as a different set from the adults, but we can learn things from pediatric cancer that we can't necessarily learn from adults, because adults have all of these environmental factors that weigh in, and it's just more of a pure environment, I guess, is the easy way to say that. With kids, there aren't as many environmental factors. It's more of a genetic problem that they're having. But pediatric data is a lot more rare, and it's a lot more dispersed. The first hospital that we went to didn't see very many brain cancer patients each year, so we moved to a different hospital that would have more of a specialty in that, and even there they didn't see that many brain cancer patients each year. And so there's a need to pull that data together because it's so dispersed throughout all of these different institutions, and traditionally there hasn't been an infrastructure to really support collecting that data. And most of the larger genomic projects that are out there, as I mentioned earlier, haven't really focused on that pediatric group. But the more we have access to that data, the more they can access the data, the faster they can do the work and pull those precision medicine initiatives together. So the database that we're working on really does give them the power to access all of that in one place. And I think that's really the thing that's going to move precision medicine forward the fastest, is just having really clear access to that data.
Oh, thank you. Sort of moving on to other issues in terms of representation, I think, Emily, you've experienced another kind of underrepresentation, being a rare variant in a rare disorder, and I know from my experience that can be a difficult process. Could you, since we're not all familiar with what it means to have a rare variant in a rare disorder, could you just give us a sense of what that's like and what it means to you as a patient and what this initiative means as a result?
Yeah, so there are over 1,900 mutations of cystic fibrosis, and in 2012 there were huge breakthroughs with the approval of Kalydeco that helped about 4% of the population. And actually, just this past week, there was another huge breakthrough where a combination therapy was approved for the most common CF mutation, which affects about 50% of the population. But like I said, I have a rare mutation, and so none of those breakthroughs help me. And watching my friends with CF get their lifesaver was it was bittersweet, to be honest. Really thrilling to watch them get new leases on life and run marathons and start families when they some of them were on transplant lists and many were very sick. It's awesome to see my friends get those breakthroughs, but I want a breakthrough like that for me too, and for everyone with CF. And so, precision medicine is really my hope for a future that we can expand on that proof of concept and find therapies that are designed for everyone. That no one of us will have a mutation that's too rare to get onto the research radar. And if there are researchers that are interested, and if there are cells to be studied, and that we can galvanize effort from the crowd to really push that forward, I think it's really encouraging and it's really hopeful, and I'm so excited to see this much attention.
And speaking of bringing people together, so Marcia, your group is actually composed of a number of different disorders, and historically it's been kind of challenging sometimes to bring together these groups and get them to fly under one banner. So could you tell us a little bit about how you were able to pull that off?
Well, when we started the Immune Deficiency Foundation, it was really before the internet was quite pervasive the way it is now, and the way we had to find patients is their physicians told them. Now, in this new era, you know, Facebook groups and all of that, we have a banner. We do a lot for our people, but we have our own social network. They have their little social networks. Some of our disorders are now kind of creating you know, something just on SCID, on hyper-IgM, on CGD, but they all understand, they all work within our framework. We realize we all have so much in common. It's the, whether it's a B-cell deficiency, T-cell deficiency, or phagocytic, or some other combination thereof, that most of them get it, that we're in this together, and the research, a lot of the research that's going to improve one disorder is going to improve another. Used to be that antibody deficiencies, you know, you're just missing immunoglobulin, you replace the immunoglobulin for many of these disorders. Now we find out that they have very serious autoimmune disorders, and how do we treat them? And right now we're looking at the possibility of Remicade for interstitial lung disease. It kind of goes, you're suppressing the immune system in someone who's already immune suppressed, but there seems to be a lot of hope there. So I think the Immune Deficiency Foundation you know, really creates a home for a number of disorders that alone would you know, not have the clout and not have the voice that they have.
Wow. So in just a moment, I'd like to move to getting the audience to ask some questions. So start thinking of your questions now. And in the meantime, one last question for sort of the panel at large. You mentioned at the start of your answer before the internet. And of course, we're now after the internet. We have the internet now. So I was wondering if you think there's an avenue for social media to play in the Precision Medicine Initiative in terms of equity or engagement that wasn't available, say, 10, 15 years ago.
Oh, it's huge. I mean, it's totally changed the game. You obviously, you know, you can go on to the internet, look for people who have, do you have common variable, but also have malabsorption issues, and all of a sudden people are coming together. Then you have a cohort. How do we work together? And we're finding what we're trying to do through our PI Connect, for instance, and this could be in any disorder. Then, wait a minute, there are physicians out there that are interested in this group. We're at our national conference that we have every year. We have some very rare groups there. There's a, you know, 2 years ago I hadn't heard of natural killer cell, and all of a sudden we have a bunch of patients who are interested. We have a researcher who would love to have a you know, a session on that. So now we're going to be doing things on natural killer cells. That it's really been the internet that have brought the patients together and brought them to us. And our goal is we've got to give them a home and find out what to do about it.
Emily, did you want to add to that?
Yes, I did. So I think social media and digital technology are having an enormous impact on the entire, on everyone, and particularly in the area of health. I think it's having an enormously profound impact on rare disease communities, and especially actually the CF community. Little known fact is that people with cystic fibrosis cannot be near each other because of unique cross-infection risks just between people with cystic fibrosis. So, you know, people who are going through and living with the same disease that I have, I can't even be in the same room as them. I can't be at the same fundraiser as them. They are my compatriots, but they're also my biggest threats. And so social media provides an amazing lifeline for me to connect with the people who live this disease, you know, just like I do. And it's a source of support, it's a source of information, and it's also a powerful source of connection. And I think that is, you know, building these communities from the bottom up is really powerful, and I think it actually has huge implications for the Precision Medicine Initiative. And I'm really excited to sort of see all those forces come together.